to the meeting Zena Etheridge, who's going to be the new chief executive of the integrated care system. And also I'd like to take the opportunity just to pay thanks to Tracy Fletcher, who I already have thanked Hackney for her time, and she's stepping down as chief executive of Homerton. But also to Alwyn Williams, who last week announced that Alwyn, you were stepping down as chief exec of the Barts group of hospitals. Alwyn, you've taken the hospitals from special measures to where they are now, back into a much firmer financial position, and just judging by the reactions that members of staff have had in the last week or so to your leadership, it's clear that you've been highly respected and you're going to be greatly missed. So thank you very much from us for all your service. Alwyn, can I just invite you to say a few words, if you may, about your time and any reflections for us going forward?
Gosh, I think I need a bit of notice of that, Ben. Thank you. Well, yes, it was a very big decision for me. I've worked now for 42 years in the NHS, a lot of that in East London, in many different roles, and it's been a great privilege to have worked so long in the NHS for 4 decades and working with such talented and committed people. I wouldn't have wanted to work anywhere else but East London. I live in East London. I've worked much of my career in different parts of East London and in a variety of different roles within the NHS. And if I've been able to play a bit part in all that the NHS has achieved in North East London over that period of time, then it's all been worthwhile for me. And certainly, in the next few months before I go, I'll continue to be working hard to make sure everything's on a very sound footing going forward. But Ben, thank you very much for your kind words. And I am very optimistic. I'm probably one of the few people that worked in the NHS before the internal market, and I was actually working in 1990 at the Royal London Hospital, and our mission at that point was to develop an integrated care system. And if only perhaps we'd been allowed to do that, but clearly we went through further structural change. And I really think, having been through COVID and the pandemic, it's accelerated in so many ways, the ways in different parts of the system are working together, not just within the NHS, but with our care partners. And I really think there's such a bright and I'm being very optimistic about the future. I think it's that there's I think clinicians and people working in the NHS, and I'm sure more broadly across the public sector, really want to work collaboratively within a system that rewards that and basically rewards how we work together in terms of systems of care and looking at population health. So I'd like to wish everyone the very best for the future in North East London, and I'll clearly be watching as a local resident and someone who will have a great interest in future developments. But thank you for all your support, everybody, for a long period of time.
Thank you, Alwyn. And Tracy, you missed my. I think you've already heard my. I've already thanked you, Health and Hackney. But again, just in this forum, so it doesn't go unnoted. I think I've worked with you for a number of years now, both as a governor at the Homerton, but you've done a fantastic job, highly respected by the staff. You've taken it to an outstanding status, and you've kept what is a small hospital in very good financial shape, and that has provided stability for Hackney over a number of years. Thank you. You'll forgive me for not coming to you as well for a. thank you for coming to you. You've already had the opportunity to speak to us in Hackney, so thank you. Can I just say before we go on, I know Zena is joining us. Zena, you are a week or so into your job. We welcome you. We're delighted that someone with a local authority background has been appointed to this role. I appreciate. Can I just invite you just to say a few words? But I appreciate you being mainly in a watching brief for this meeting.
Yeah, brilliant. Thank you very much, everybody. I'm not sure I ever thought I would say this about being part of a council meeting, an evening council meeting. It's actually really nice to be here because it feels like I'm back in familiar territory again, having, as you say, been in, I think this is day 6 of a new role. My background, as I think you know, is I've come from being Chief Executive of the London Borough of Haringey for 5 years, and I'm really excited about the opportunity that the ICS brings, actually for lots of the reasons that Olwyn set out. I am really passionate about the opportunities available to kind of improve the health of the whole population, and in particular to tackle population health inequalities, and the opportunity that working with really tightly, I can't think of a better word of describing it, really effectively at place level and at system level, to kind of focus on the same broad objectives and the opportunities that gives us to be really innovative and flexible, but at place level, but also to bring the advantages that being part of a wider system can bring. I'm a big fan of local authorities. I wouldn't have worked in one for 9 years if I wasn't. I loved being the chief executive of a local authority, and the chief executive of a local authority that has many of the same characteristics as the boroughs of North East London do. So some really deprived populations, some really diverse populations, and actually working as part of the North Central London system over the pandemic, I saw the opportunities and what we can do when we all work together. So the vaccination programme, for instance, we would never have thought we could have achieved what we could achieve, what you've achieved in North East London, what we achieved in North Central London, in really getting to the parts of our populations that kind of other vaccination programmes and other programmes haven't reached, if we hadn't been working so effectively in partnership. So I'm really excited about the opportunities to further strengthen the partnership working with local authorities, with Health Watch, with the wider voluntary and community sector, and in particular with the residents of North East London, so that we're really genuinely building improved health and well-being for them in partnership with them, rather than thinking about kind of designing services separately for them. And I think there are some things that we can say about the ICS when we come on to kind of where we are, and maybe I'll say a few more words then when we come to that item in the agenda.
Thank you, Zena, and welcome. I think what I want to do, I want to move on to the agenda. I think I will want to ask Jacqui, maybe at item 5, where we are with the process for Olwyn's replacement. I know where we are with vaguely, well, roughly where we are with Tracy's replacement. But I do just want an update from Jacqui on that, but I'll maybe come to that at item 5. So then very quickly, declarations of interest are the standard ones. They're in the agenda. I haven't been notified of any urgent items. So let's move on to item 4, which is the structure of the ICS. Thanks for the updated presentation pack. I think Mary might be, or Henry might be leading on this in terms of it. We're aware of the update, I think, from national guidance that elected members can now sit on the board. So maybe just a brief update on where we are with that. And then I think, for me, one of the main issues that still remains outstanding and unclear is we appreciate at ICS level that will fund the acutes, but then all the other money, all the other funding that the CCGs used to fund their local systems, where is that going to be funded from? Is it going to be funded from an overarching system level, or is it all going to get devolved down to place? And so just some more detail there, if we can, as to where we are with that. So I don't know, Mary or Henry?
So it's going to be mainly Henry, but I just wanted to, as we're thanking everybody, just thank Henry, who stepped up. I think it was for 10 months as the ICS lead and head of the CCG, and skillfully led us through the pandemic and the requirements of transition, and also delivering day to day, and was very inspirational. So staff will continue to be so. I just want to say thanks to Henry. In terms of local government representation on the ICT Integrated Care Board, in North East London, we always thought it was going to be thus. There was a time when we thought it wasn't going to be permitted, so we looked at executive membership, but we now are back where we originally were in terms of having elected members on the Integrated Care Board. But I'll now hand over to Henry to talk about the money. Henry.
Thank you, Marie, and thank you as well for your kind words. It's been a real privilege to lead the organisation through this process, but I'm absolutely delighted that Zena is here with us, and we can work together to establish the ICS as the most progressive ICS in the country. The pack contains quite a lot of information. Some of it builds on information that you've already seen. So I was going to try and draw attention of the committee to the items or the elements that are new. You've already mentioned the change in NHS England policy around the elected members. Although, just as a point of clarification, that's membership or partner members rather than any other kind of member, which is fine. We wouldn't have expected anything else, but that's how that's going to work. Obviously, the other key thing is the date for the establishment of the ICBs has moved to a target date of 1st of July. We're not quite sure what target date of 1st of July means, but we're working on the basis that it will be the 1st of July, and that's how we're going to progress. In terms of where we're up to, so Zena has obviously started last week, and we're hoping to complete the recruitment to the other 6 ICB executive posts by the end of March, which includes a couple of new roles, including the statutory new role of Chief Medical Officer. We'll also then be...
Henry, just quickly, those 6 roles, that includes your position as Chief Financial, your role position, Chief Financial. Can you just run through what they are for everyone?
Okay, so we've got my old role, which is slightly amended, is now the Chief Finance and Performance Officer. The Chief Nurse Officer and the Chief Medical Officer are the 3 statutory posts. We then have the Chief People Officer or Chief People and Culture Officer, the Chief Development Officer, and the last one is a kind of innovative new one, which is the Chief Participation Officer, which is one that we're keen to develop, which we hope will kind of broaden our community engagement and our ability to really have resident and patient participation at the forefront of everything that we do. So those are the 6 executive roles, and then we will also have 3 non-executive roles. We had a bit of an arm wrestle with the region about whether we could have 3 or 2. But we've managed to get agreement to have 3. So that's good, and we will be going out for recruitment for those shortly after we've completed the executive roles. Do you want me to come on to the kind of key money question, and I'll go straight for as straight up an answer as I can, which is genuinely to say that we are still working through it. You might expect me to say that. What we absolutely don't want to do, though, is to impose some kind of top-down imposition in terms of a model. This is very much our kind of intention is to build this bottom up and make sure that the finances don't drive the overall governance. We need to have a governance and a financial flow mechanism that supports the objectives that the ICS is working towards. So we need to make sure that we are really clear that the partnership plans are all fully kind of deliver those objectives. Then once we've determined precisely what the place-based partnerships and the provider collaboratives need to do to be able to deliver that, we can then work out what governance they require in a bit more detail. And then at the end of that, we will work out what is the funding flow required. We are very much kind of supportive of the concept of things happening at as local a place as possible. So our working assumption will be that we would only retain stuff at a NEL level that is best done there, and everything else on that basis would be as local as possible. So we expect the place-based partnerships to have pretty much the same degree of flexibility that we would expect to see now. So that's our kind of working hypothesis. But there is still quite a lot of stuff which is unknown. We seem to have the legislation is going through the Parliament at the moment, and there seems to be quite a lot of white papers that keep popping out and not necessarily changing our plans, but we have to take due consideration of those as they come. The integration white paper has quite a lot in there that will support the things that we want to do in terms of giving real focus to local partnership working. But we do need to make sure that we do this in a way that supports that, and we're definitely not rushing into anything. But that work will continue, and the fact that we've now got 3 months grace with the July establishment date gives us a bit more breathing space to be able to do that. But that's how that's the way we're working towards that.
Thanks, Henry. Okay, sorry, can I just say just on that point?
Yeah.
So when we're next here, and I don't know off the top of my head whether that's in June. Well, you will know by that point, because I think it's only a few days before you usually start. Can we at that point please at least have just a 1 or 2 page diagram about sort of saying where that funding that the CCG, other than the Acute Trust funding, that the CCG used to hold, and just with arrows saying, is it either going to be funded at a system level, or is it going to be funded at a place-based level, just so we have some oversight and understanding. And that's not loaded in the sense that I understand the point that it might make sense for something to be funded at a system level, but just so we have some sort of idea as to what the new framework looks like. So can I just ask for that? For I think what will be a day or two before it's due to take place. But sorry, I interrupted you.
No, I wasn't going to say anything more, Chair. I was simply going to say that the rest of the pack has got some fairly detailed information in there, so I wasn't going to go through it anymore. I would just leave it there and open it up to questions. But yes, we can certainly give a much more detailed update in the June session.
Members. While I think there will be, while other members are possibly thinking, can I just ask one in terms of payment by results? I mean, I think there's reference to it in the pack, in the presentation, in terms of sort of moving away from it. But noises in the last few weeks, I think it emerged, is referenced in reintroducing that, or some element of it, to go through the backlog in terms of surgery. I mean, how is a payment by results system which will drive sort of acutes, because they will have a financial incentive, how is that consistent with a joint working, sharing lists, sharing surgery to get through? How do the two sit together?
Yeah, so it's a really, really good question, and I agree with your fundamental point that a purely activity-driven payment system is not one that has served us well in terms of tackling health inequalities. If anything, it's resulted in increased health inequalities. I think the way that we would like to look at this is that it will support any kind of additional payment for additional activity over and above core will support our ability to be able to use the kind of flexibility of capacity that we have. So in other words, in order to deliver the backlog, we might find that there's a better way of configuring services as we go, and there might be certain sites that can flex capacity up and down. That will then enable us to target that spare capacity and deliver the reduction in the backlog in a more kind of coordinated way. That means that some sites may do more activity than we could anticipate at this point in time. The fact that ICP, which is the infection control and prevention rules, are so stringent now, but will change in due course, is also a further complexity that means that some sites might in the future be able to do more activity than we might expect them to be able to do now. That means that means we might be able to put on weekend and evening lists that we might not be able to anticipate now. And if we're going to do that, we need to be able to effectively fund those as they happen. So the core funding mechanism will be based on a population approach, but we might then have additional activity-driven targets on top of that will help clear the backlog. But yeah, it won't be under our watch, it won't be a return back to PBR.
Councillor Adams.
Thank you, Chair. Thank you for your presentation. My question is about the two LA representatives. Can the two LA representatives, can they be elected or cabinet member or council leader? Just want to clarify that.
Councillor Adams, as in whether the elected representatives would be the ICB, whether they would be the mayor or council leader, or whether they'd be the healthcare. Mary, any guidance on that, or what your thinking is?
So there's no guidance. What we've asked is our local authority colleagues to decide that between themselves really. There will be some guidance published in May at some point, and it's very clear that people there are not representing their particular organisation, but are part of a unitary board. But other than that, we do not yet have a nomination process, but we're expecting the local authorities to come together and agree the who of that.
Fine, thank you. Any other members? Councillor Snell?
I wondered if somebody could talk us through the transition for jointly commissioned services. Obviously here in City and Hackney, we've done a lot of work across the different areas of the health economy, looking at better ways of integrating adult social care and NHS services. And I think they've delivered results. So I just want someone to talk me through. There's a lot of talk about single accountable bodies, particularly for the financial management, how that pooling of budgets and joint commissioning to get a better outcome will be taken forward. Exactly who will be the people who push it forward?
Okay, thank you, Councillor Snell. I'll probably ask Marie. I think we've got Marie Price on the call to follow this up. But the central point would be that this gives us the opportunity to use those models that we have and then to build on them. We certainly would not be unwinding any of that, and the work that has happened in the City and Hackney ICPB over the last 3 or 4 years is an excellent model of that, and we will be looking to retain all of those benefits and progress further. So those are the committee structure that we have at the moment is 3 separate committees that meet jointly, which means that the 3 organisations are able to effectively carry out one meeting and have one discussion and deliver one kind of outcome for the residents of City and Hackney. We want to continue that. It might be that the precise nature of the committee structure could change to make it even more integrated than it is now, but that's a matter for how the legislation permits that, and all of the organisations are working through that with their lawyers. But certainly we will be reinforcing that and retaining all of those pooled arrangements.
Thank you. And Councillor Masters?
Thank you. I've got a question about finance, actually. In your papers, you refer to the significant staffing involved in managing sort of budgets at this level. And I'm just wondering whether any work's been done to sort of look at the costs of our new integrated care system and whether it will end up being cost neutral because of the kind of savings we might make in having more efficient services, and whether that's an ambition or whether it's sort of costing considerably more. I mean, to what extent is that being monitored?
Thank you. It looks like Marie's about to come in, but I mean, the short answer, Councillor Masters, is that we absolutely will focus on this as part of the work that we need to do. We don't have a calculation at this point in time of what it will cost, but we do have an aim and a target for it not to cost any more than it currently does. Obviously, we are, we're required under the legislation to establish the ICB in the way that we have to, and so we're following that process, and we will come back round, as we have established at the point after we've established the ICB Executive Committee and then the next level down, to then do a review to ensure that we're doing that. But the intention at this point in time is not to not to exceed that, and the ICB will have a running cost allowance. The legacy CCGs collectively underspent their running cost allowance, so and we expect the running cost allowance for the ICB to be the same. So we will look to continue to do that.
So Henry, can I just make sure I've got this right? So say we come live on the 1st of July, all the existing CCG budgets, whatever they were, all get pulled together, and then the integrated care system gets that. But that will presumably extend to the end of a budgetary cycle that was previously agreed with those CCGs. How long have we got until there's a new sort of budget settlement for each ICS patch, as it were?
So we are in a bit of a slightly odd situation, because the national funding process is, we were working under the emergency regime. We are working through that now. I think it's probably best if we give that update at the next session, because we'll have more information. So at the moment, we know what the total ICB allocation will be, but we don't, which will be about 0.7% less than it was in this financial year, because this financial year included a huge increase in resources for COVID. What we don't have is the precise nature or the precise kind of the way that we will allocate that across the different committees. Until we've done that work, we won't know that. But we will bring that back at the next committee.
And how long are the settlements, the financial settlements that you're giving? Are you giving it on a yearly basis, or are you giving it on a 3-year trajectory?
So under the long-term plan pre-COVID, that we had a 5-year settlement, but this year we've just got for next year, because of the emergency regime and the emergency pandemic funding, we've only got 22-23 clarified. We expect, once we've gone through this year, that we will go back to much more stable long-term projections, but we are basically going from one year to the next during the emergency regime.
And we as local authorities, sorry, Councillor Hunt, I'll bring you in one second. We as local authorities are very aware of sort of the levelling up agenda and sort of consequences that sort of has on a local authority level. Arguably less money sometimes being given for demographic factors, say where some of these London boroughs have benefited financially. I mean, is there a risk, because of that agenda or the way money is otherwise settled out, that the area could lose out because there's a different weighting given to other factors?
So I think that will be a matter for the ICB to consider, because the overarching requirement will be to reduce health inequalities. That we will also we're also committed to doing that in a way that minimises any instability. So we won't be making any significant changes to that kind of configuration, quickly. But over time, we will need to give due consideration to those. What is the best structure that will reduce health inequalities across the whole of North East London? I know that's a little bit of a woolly answer, but until we've got to that point, that's what the requirement will be for the ICB as its statutory duty.
Councillor Hudson.
Forgive my scepticism, but in my experience, every change to the NHS seems to involve an increase in administrators and administrative costs. So I should be interested to see in June what the position is and whether you have managed to get a more streamlined organisation with less costs. But I remain sceptical.
I think I'll take that as a comment or observation rather than sort of require an answer. Okay, at time on this item, so thank you for that sort of more focused update, and then definitely, obviously, when we meet again at the end of June, I think obviously this will need to be the first item on the agenda for hopefully a more detailed update, exactly where we are with who decides the commissioning of all those other areas other than the acute trusts, and then any other further details. So I'll move on to the next item on the agenda, the partnership update. Again, we've got Henry, we're joined by Ulwyn and Tracy from the acutes, and also Paul Calaminus from East London Foundation Trust. We've got several items that are in the update. I mean, I probably want to focus less, if I can, on the COVID items, simply because we've given that a lot of attention of late, and perhaps more on the joint chair of East London Foundation Trust and North London. I'll come to Paul on that in a minute, and also where we are with waiting lists. Before I do that, can I ask Jacqui maybe just to give us a quick update on where we are with Olwyn's, the process for Olwyn's replacement? I thanked Olwyn before you joined us, Jacqui. If you can give us an update and a timescale on where we are, and also just clarify that we are just appointing to Barts. I know you're joint chair of both, but we're not proposing, unless I've got this wrong, for there to be a single chief exec across all the hospitals, or have I got that wrong?
Yes, and I did hear you talking about Olwyn as I was sort of on the phone at the beginning, and clearly Olwyn leaves us with a situation at Barts Health in terms of bringing the organisation out of special measures, and also developing the group model, each of the hospital sites to interact with the place-based leadership that is clearly part of the ICS development, and also leading the collaboration between Barts and BHRUT, where I reported on that at the last OSC, and we're continuing to make important progress, particularly in helping to tackle the elective backlog more quickly than it would be possible to do were we not collaborating like that. So when Olwyn announced her retirement, which will take place from July this year, we needed to consider how we ensured the capacity and capability to make progress on the collaboration and the priorities that we'd set there without unnecessary organisational change, and maintaining stability for the leaderships of both Barts and BHRUT. But we did think that the best way of ensuring that we continued with the progress on the collaboration, and we also provided a strong voice and strategic leader to be able to contribute to the development of the ICS in the way in which you've heard it described, and also to be a strong voice for ensuring that we were able to bring resource to North East London, that it made sense at this point to recruit a CEO who would operate across both of the trusts. The two trusts will remain as separate statutory organisations with their own boards, individually accountable to their patients and to local stakeholders. Both boards will present public reports about progress, and will obviously report to overview and scrutiny committees and local stakeholders. And it's our intention to begin that recruitment as soon as possible. And alongside that, in terms of the sort of leadership of the trusts, as I said, there is quite a lot of work being done to strengthen the site-based leadership in Barts, and also I'm recruiting 2 vice chairs for the 2 boards as well, to be able to maintain a focus on each of the trusts as we nevertheless develop the collaboration in the way in which I've described.
Thanks for that update, Jacqui. So, I mean, to what extent is this being driven by, I haven't gone into sort of the nuts and bolts or sort of the white paper of the ICS, but I do recall sort of hearing some time ago that that they wanted to move towards a system where essentially you just had one acute trust provider in a certain sort of ICS system. I mean, is this being driven by sort of national direction, that is the way of travel? Because obviously what we're seeing here with Paul, which I'll ask him about in a minute, in terms of East and North London Foundation Trust, is that one of the main drivers coming sort of from the Department of Health, or is it coming, iteratively and embryonically from a local place level? What's the driver for it?
Well, so it's certainly the case across the country that there are increasingly collaborations between trusts and CEOs who are operating across more than one trust. What's driven this decision has been our view of what the most appropriate way of taking forward the collaboration and the benefits that are coming from it is. And we think that is providing that single leader across the two organisations, whilst also strengthening both the leadership and maintaining the leadership at BHRUT, where Matthew Traynor will continue to be the Trust CEO with the exec team there, and strengthening the hospital site-based leadership at the BHRUT side. So it is in line with developments nationally, but it's not mandated. It's a decision that we believe to be in the best interests of our patients and the benefits that we're beginning to see from the collaboration.
Okay. Thank you. There may be members that sort of want to have follow-on questions, so I may come back to you, so I don't want to take up the whole of this item. Does either, I don't know who was planning to give the introduction to this, or whether we were going to go straight into questions, whether Olwyn or Tracy were going to give a brief update to sort of the partnership update, or Mary or Henry, or can we fire straight into questions? Mute, Mary.
Sorry, I think it might be good for Paul to talk a bit about the NELFT-NELFT Chair in Commons, because that's a little bit different. But also you asked particularly about elective weights, which I think Olwyn and Tracy are best to do. So if we have Paul and then Olwyn Tracy, because that's what you want to focus on, then we've got lots of time for questions.
Thanks, Mary. So, Paul.
Thank you. And I should say, I think Jacqui van Rossom from NELFT is also with us this evening as well. So thank you very much. Yeah, perhaps if I start with the question you just asked Jacqui Smith in terms of some of what's driving this. I think we've done a lot of work across North East London for both mental health and community health, particularly over the last couple of years, and particularly, I should say, also with our service users and our clinical leads, and really trying to bind in our local borough partnerships and some of the broader work we can do. So we put in the slides in your pack a couple of examples that remain, I think, really important examples of what we can achieve. And some of what's really been driving our thinking and some of the development of the joint chair. And I suppose to pick a couple out, if you don't mind. So the first, I think, would be about children and young people. In common with almost everywhere else in the country, there's been a real increase in mental health needs of children and young people through the pandemic period. And one of the things we've been able to do as trusts working together is really bring our adolescents to work with our clinical leads and actually with our commissioning colleagues. So from across all of the borough partnerships in North East London, and really, really think about what's the service we're providing in inpatient services in Tier 4, as we call it, and what else could we do instead? And so some of that work there has not only led to more appropriate hospital admissions, slightly fewer young people going into hospital, but really importantly, young people helping us redesign the experience in hospital, about a 40% reduction in length of stay for those young people. So getting them back to their families, back to school that much faster. And then actually being able to reinvest now some commissioning, some of our commissioning resource into a new eating disorder service at home in each of the 7 boroughs. So working very much in partnership in each of the local areas. And we've managed, I think, to do something not so dissimilar with adult mental health as well. You know, we are. I can sit here honestly and say we are the only ICS in London where we are not sending adults outside our ICS area when they need inpatient care for mental health. And that has a lot to do again with the work we've managed to do with our service users, with our clinical leads. So I hope that gives a sense, and just a couple of examples of some of what we've really, really been trying to develop and work on. And so very much the conversation, both of the Council of Governors and both of the trusts, and within that conversation, you know, a range of our staff, our service users again, local authority members, has been about I think really how to take the opportunity of having chair vacancies in both trusts to think about how can we really consolidate that culture and that way of working, because there are many, many, many examples we can take forward and actually really build, really co-produce with our staff and our patients. So I won't say any more than that, but I hope that gives a sense really of where this proposal has come from and some of what we're trying to build on.
Thanks, Paul, and welcome, Jacqui, as well. And thank you for joining us. I think there'll hopefully be some questions for you in a moment. Can I just go to the updates from Olwyn and Tracy on where we are with waiting lists on the acute side, and then I'll throw it open for questions. So, Olwyn, do you want to start, please?
Yeah, I'll start. And I'll give you an update around what we call the long waiter position as it relates to people waiting over 52 weeks and 104 weeks. As you will know, this is in North East London predominantly a Barts health issue rather than a Homerton issue. BHRT also have some weights, but certainly the significant focus of work is at Barts is in relation to the Barts health waiting list. That said, what we've already been able to do very successfully is work collaboratively to ensure that the Homerton indeed, as well as BHRT, are providing good mutual aid to support Barts as the backlog numbers need to reduce. And as you know, the context is we'll focus now on long waiters, and that's in the context of, I've explained at previous meetings, where we clinically prioritise all patients, and the most urgent patients will get their life-saving surgery within immediately, and then at what we call our second order priority, our P2s, we ensure that they will get their surgery within a 4-week period. And so what we're always balancing really is our capacity and workforce to the very, very urgent, the P2 category of patients, and also clearly those patients that have waited the longest. The focus in the here and now is on both the reduction of the 104-week backlog as well as the 52-week backlog. In the last since sort of January, and as you know, we were dealing with Omicron over the winter, but since January through till last week, we have managed a 50% reduction in the 104-week waits at Barts Health. As I say, that's in part due to the collaboration as I've described as well. But we were at about 1,800 patients at the beginning of January, and we're now down to 900. And we continue to reduce those numbers as we go forward week by week. So we've already achieved a 50% reduction, and we're aiming by the end of March to get that number down to about 250. So making some considerable inroads really into that backlog. There is now a national elective policy, which you may have seen, that was published a few weeks ago, and the national requirements are that all 104-week waits are eliminated by July. So that would require us to effectively ensure in the first quarter of 22-23 that we then move from the outturn from March through to an elimination of those waits by the end of June. So I think good progress. We'd always like to go faster, but as I say, it's constantly a balancing act in terms of making sure we're treating the whole spectrum of patients needing surgery, but clearly a very big priority placed on patients that are clearly now waiting far too long for their surgery. In terms of 52 weeks, again, we've reduced well over the last 12 months. Again, we've reduced those numbers. As you will remember, I quoted some very high numbers of circa 11,000 at the end of the second COVID peak, and we've reduced those numbers now to just over 8,000. So that's about a 54% reduction over the past 11 months. And again, that rate of reduction will continue in the coming year. in terms of the national ask, and what we're doing currently is planning, again through collaboration and with system partners, to effectively pull together our plan for elective recovery for 22-23. And we're as confident as we can be, as at this stage we haven't quite completed that process, that we'll be able to deliver effectively what the national requirements are for backlog reduction. And that's basically during the course of 2022-23, as I say, to have all 104 weeks eliminated by July and 78 weeks eliminated by the end of 22-23. And then nationally to get to an elimination of all 52-week waits by March 25. And I think there's every chance that London will be able to do that ahead of the national requirements as well, which is really, really positive. What I would say is, you know, we've talked previously about how we are working together across these surgical centres of excellence, where surgeons are coming together to deliver effectively low acuity but very high volume surgery to effectively treat as many patients as we possibly can as quickly as possible. And clearly that way of working will need to endure, and I'm very conscious in the coming months we'll have to come back and describe to you how that service configuration in terms of the provision of surgical services is likely to need to be retained going forward to certainly deliver on the requirements that we have over the coming years. So I'm very conscious that we, as you will know, we put these in place as a COVID response, but clearly, you know, given the scale of the challenge, not just we have in North East London, but indeed across the country, that configuration of surgical centres will endure, and we are currently looking at ways in which we can enhance and expand effectively NHS capacity in North East London next year and the year after, to give us greater NHS capacity, less reliance on the independent sector, and indeed helping to future-proof going forward, given what we know about population growth. So there's a strategic element of developing the capacity and the workforce needed going forward, given those future demands of our population, as well as catching up now with the COVID backlog as quickly as we can for the people who live in North East London.
Thanks, Olwen. And Tracy, can you just give an update from the Homerton's perspective on sort of where we are with waiting lists, or if that's not your biggest priority, what's the biggest focus right now for Homerton?
So, I mean, I think Olwen actually included elements of the Homerton work within her summary, and although the waiting list at the Homerton for the patients we've amassed ourselves over the course of the last 2 years is below the thresholds in which we're required to achieve, although we do have some over 52-week waiters. Our priority, and I suppose our area of work with Barts Health has been to try and establish which patients can more easily transfer across to the Homerton to be treated there, in order to help alleviate some of the long waiters, either directly or indirectly by providing capacity for Barts Health or freeing up capacity for Barts Health, in order that we as a overall system can try and get back on top of some of these positions. Remembering, of course, that as I've said numerous times before, patients of the Homerton, and particularly of City and Hackney, have always over many years followed pathways for appropriate treatments over to either the Royal London or St Bartholomew's, and that way of working has been in place for many years. It has happened in the past that patients have been have transferred back to the Homerton in a mutual aid sort of way. We called it other things in the past, but this is something that we need to work together collectively on, and secondly, it's an area in which the Homerton can contribute to some of the pressures we're seeing across North East London. I would also absolutely concur with there is a need to get back on top of our backlog, but some of the conversations, if not many of the conversations pre-COVID, were around the developments that were underway within North East London and the additional population that would bring. And we've now sort of for two years on from talking about those subject matters, and we again collectively need to really think through what that impact is, or what that population increase is going to have on our already existing under pressure services. So I think the establishment or the continuation and I suppose development of how we think about clinical teams working together to solve those problems on a slightly wider geographical scale, I think is a really important next step. That doesn't come easy because we've all been working in very, very different ways over the past 25, 30 odd years. But nevertheless, I think it's an area in which we've practiced over the last 2 years, and now we need to establish it on a different footing, and not on a crisis footing, but much more on a planning footing, or a planned footing. So that's probably about as much as I'll say. Thanks.
Thanks, Tracy. Members' questions? Councillor Snell?
I'm interested in understanding how we're creating this extra capacity to get through this backlog of elective surgery. So mutual aid presumably means that any one of the hospitals that has spare capacity is then helping out other hospitals. But does it also involve changed ways of working? I mean, give a silly example. Does one person focus on replacing hips and another person focus on replacing knees? What are the other aspects of actually getting through more of these operations and clearing up the backlog? What are the other ways of working that allow us to get more people through the system quicker?
Olwyn, do you want to deal with that?
Yeah, so yes, so the way, I mean, this was very much a London strategy as a response to COVID, was the development of what we call high volume, low acuity surgical centres. And these are for the operation. So to remember, all the outpatient pathways still remain local. But if a patient, particularly, and it's day case surgery, what we are developing, and you know, this is still work in progress, but some key areas of consolidating services. So for example, the Homerton, Tracy, you might want to say a little bit about the Homerton specialising in gynae and general surgery on behalf of North East London. If I take Newham, we've got an orthopaedic centre. And effectively what that means is we're able to bring the clinicians together. They're able then to treat more patients more quickly because they're able to be more productive in these centres. So effectively moving, you know, if we want to bring to life what we mean by integrated care and collaboration, it's actually, you know, taking down some of these historic boundaries and barriers between organisations and clinicians working together, so that across that network of hospitals and different centres that are specialising in different parts of surgery, we're able to treat more patients because the clinicians are coming together, and the throughput then it can be organised in a way that is much more productive. We are still dependent on the independent sector. I mentioned that we're currently in planning to see whether we can secure capital for North East London to develop more NHS elective capacity and be less reliant, clearly, as a consequence of that, on the independent sector. We will be able to come back to you in June and talk a little bit more about that, because we will have completed the planning round and we'll be clear what those specific plans are. And it makes a lot of sense to do that, as I said, and as Tracy has outlined, that because that starts to build our overarching response to population growth. One of the key things that one of our constraints currently is that we're clearly having to segregate patients still because of Omicron and COVID. And we've got very stringent infection control processes, which is clearly having an impact on how many cases, for example, we can have within each theatre each day. We think in the next few months that we'll have a bit more flexibility. Now, clearly our predominant priority is to keep patients safe so they can have their surgery safely. But we think there'll be some relaxation. And again, that will enable us to treat more patients as well. So I'm talking very much about the admitted patients, when patients need to go for surgery, but there's also an awful lot of work being done across the system with our primary care colleagues, hospital clinicians, really looking at what we call pathways of care between community services, primary care and acute services. And actually we've developed some quite innovative services in North East London, building from some good practice. You find it in parts of North East London, but we've really taken the learning and developed really good practice where we've developed community-based responses to some of the patient needs as well. And we'll continue to do that.
Thanks, Owen. Can I just bring in Cllr Masters?
Thank you. I kind of want to pick up on your question. You're talking about you were talking about being in the sort of shift in position in terms of numbers of people going through surgery. One of the things that worries me at the moment is it feels like central government has declared the pandemic over. And there's a question we've got posted on our list for this evening around the impact of free lateral flow tests. And I'm just worried that we're being led by this kind of political narrative that the pandemic is over, and whether we're using this to justify a higher flow of surgery when actually the level of risk is still there. And I'm just interested in knowing what your impression is as the person on the sharp end, because obviously as councillors we don't have that access. We don't know how things are looking on the ground. We're just sort of hearing politicians of a certain party declaring that we can now sort of stop wearing masks and go out and stop isolating. So I'm just interested in knowing whether this is actually sort of justified in what you're seeing.
I mean, just very briefly, just to respond to that, what I would say in the hospital context, we are still compliant with very stringent control of infection arrangements for patients to ensure that we minimise the risk of transmission of Omicron. I mean, we've got, our numbers are much lower, and we know the severity is nothing like previous COVID waves, but what we need to do is reduce transmission. So in hospitals, you know, mask wearing, social distancing, segregation of patients, making sure that all theatres and areas are cleaned thoroughly between patients, all of that which has been going on continues. But clearly that has an impact on our ability in terms of productivity and the efficiency really of the way in which we're working. So we will be taking clinical control of infection advice to make any changes to that. We'll work together across all the hospitals to make sure we're consistent in that. But I think in the next few months there'll be a degree of relaxation. I'm not saying it will be entirely relaxed, but I think that there will be some relaxation such that we will be able then to ensure that the utilisation of theatres and the facilities that we have can ensure that we can treat more patients. But our first priority is to keep patients safe, and all of those measures are still in place.
Thanks. I've seen Councillor Sweden and then Councillor Hudson. So, Councillor, I'll take these two questions together. Councillor Sweden.
Thanks very much, Chair. And just before I ask my questions, I'd like to thank Alwyn for her work personally. I remember asking her how long she was going to stay when she started, which was my favourite question. And unlike most of the other people that I've asked the same question, Alwyn has stayed and given sterling and sustained service. So thank you very much for that, Alwyn. With regard to the mention of mental health, I noticed that a reduction in inpatient treatment was quoted, but I just wondered how we were doing and whether we had sufficient inpatient bed capacity and how we were doing in terms of bed occupancy levels in terms of the acute mental health sector, and to what extent community treatment orders have played a part in any reduction. My second question relates to the mentioning of cancer diagnostics and a very laudable program in trying to get to harder to reach groups, which obviously has implications for the addressing of health inequalities. Having been successful in the uptake of diagnostics, how have we got sufficient capacity to treat? Before COVID, our statistics for the diagnosis and treatment of cancer were poor when compared with our equivalent other European countries. So I just wondered how we were doing, assuming that the programme for hard-to-reach groups diagnostics is successful, will we have the capacity to treat them and treat them in a timely way?
And before we go to answers, can I bring in Councillor Hudson at this stage as well, please?
Chair, I've got two questions, and I'd like to ask them separately, please, and I hope they can be both given very short answers. There is reference to, they made a reference to using independent hospitals. What is the relative cost of this to, for example, having an operation within in the NHS? Is it a percentage more or a percentage less or about the same? And if the answer is don't know, please say so, and then give us a written answer afterwards rather than giving us a long waffle.
Question, or was that was the second?
There is a second question, Chair, but I really would like a short, precise answer.
Well, I've got Councillor Hudson. I'm trying to wrap this up. I've got 10 minutes left.
Well, my other question then, and also I would like a similarly short answer to it, but make sure they are answered. Is there is reference to active recruiting? To what extent are you losing staff, and are the numbers going up, down, or staying about the same? And again, if the answer is don't know, please say so and give us a written answer later rather than waffle.
Thanks, Councillor Hudson. Can I first go to Paul in terms of the where we are with inpatient treatments and community treatment orders, to give us an update there in terms of capacity, and then I'll come to Alwyn on cancer diagnostics and maybe then the costs of dealing with private and recruitment. So, Paul.
Thank you. Let me first of all say, if I could send the exact percentages as a written answer, I'd be grateful. But we are between 90 and 94% occupancy on average at the moment. What we do see is a lot of variation between male and female and between boroughs within North East London. Where we, in terms of the impact of community treatment orders, I think we're probably seeing a reduction overall in the use of community treatment orders, and certainly with some of the review of the Mental Health Act, them being used less frequently, but more and different crisis offers for people, and some enhanced crisis lines, which we do think is making an impact overall.
Thanks, Paul. And Olwen, can I go to you for the other three parts?
Yeah, thank you. Thank you, Councillor Sweden. The issue about cancer diagnostics is a really important issue, and just to say that there is further investment being made into diagnostics. So if we take, for example, the Mile End Early Intervention Centre that was opened about a year ago, and again that was a collaboration across the Trusts and the ICS in North East London. That there's a similar development at Barking Community Hospital, and there'll be further diagnostic centres as we roll this strategy out in the coming years. So more investment in diagnostics is absolutely needed. We've had quite a bit of that in North East London. We need more of it. But for example, because of the Mile End Centre and the work within our hospitals, we've cleared our endoscopy cancer backlog really well, and I think we're best performing in London. So that does show where we've made it investment, but further more to do as part of the planning for 22-23. And we can come back to you in June to explain more about what that looks like going forward. Just on the IS, we've more or less extricated ourselves from our inner London IS providers, but for the outer London.
Olwen, IS stands for?
Sorry, independent sector. That was independent sector, private sector. So the question I think is there a cost differential? Basically, for the outer London independent sector contract, for which we're particularly reliant on, we secure services from the independent sector in outer North East London at NHS tariff, so it's the same cost. And then the final question on workforce, broadly the answer is there is a degree of stability in workforce overall numbers, but that masks that we're doing an awful lot of recruitment and there is still a turnover. And clearly, given the challenge we have around elective recovery, we need to increase the workforce. So that's the key challenge.
Thank you. We've got a few minutes left. Can I just go back to the sort of joint chair of the two health trusts? I mean, to what extent does I understand the argument in terms of consolidating sort of surgical delivery, you know, say of a hip operation or diagnostics, because okay, people have to travel further, but you can do in bulk, and arguably you get a better quality. And I think there's an evidence base, you know, academic evidence based underpinning that. But in terms of this sort of expanding governance, I mean, is there any? I mean, is there an evidence base to say that governance is more effective when you spread it across such large number of organisations? I think East London Foundation Trust has got interest in Bedfordshire, I think, historically, and maybe a few other places as well. I mean, that's a significant geographical footprint. I mean, how are we judging the quality and the effectiveness of this overarching governance? So I don't know whether that's Paul, to you really.
Yeah, thank you. Let me start, and maybe Jacqui would want to add something from an ELFT perspective. So I think what we found is that there are approaches and areas of collaboration where we've really demonstrated benefits and outcomes to our patients, outcomes from our clinicians, our teams working with our patients. And I've given, you know, I won't repeat that couple of examples I gave. I don't think, sorry, not that I don't think, there's no, so certainly what hasn't been part of the conversation like council governance, for example, is an equivalent conversation about, say, joint chief executive between the two trusts. So this is very much about how do we really support us to collaborate well and think differently about what we've traditionally called commissioning and providing. I guess going back to some of Orwin's reflections on when she began at Royal London, and could you create an integrated care system? So this hasn't, certainly in the council and governor discussions and board discussions, been about trying to create trying to go beyond the focus on collaboration, but it has been a lot about our experience over the last couple of years and what we've been able to deliver, and really wanting to continue that. So I hope that answers your question.
Thank you. And Jacqui van Rossom, I mean, have you got anything else to sort of add with respect to this about what you see are the advantages of the joint governance? Jacqui, you muted.
Apologies. Yeah, no, too many tabs open. No, so thank you, Chair. No, I think it's really what Paul says. I mean, this is really our aim is to improve the outcomes for our service users by building the collaborative that's already in place between the two trusts. And you quite rightly mentioned the fact that both organisations work in other geographical patches, and in Essex, as an example, for NELFT, we have a very strong collaborative there with our Mid and South Essex partners, but very much see the chair role which has been in supporting that. And we would look to, as I think Jacqueline said earlier, about how we then give support to the joint chair in terms of increasing capacity and portfolio for our other non-executive directors, so that we don't dilute the chair's presence and responsibilities. So we're really quite excited about this, that goes forward in the London space particularly, but also helps us in the other geographical patches that both organisations work in.
Thank you. I mean, I suppose I see Cllr Adams and Cllr Masters. I'm over time on this, but I'll quickly take these two questions together and then draw it to a close. Cllr Adams?
Yes, Chair, it's just a brief one on long COVID. I'm just wondering whether they can actually, give us an example of practical care that's available for somebody suffering from long COVID, apart from the awareness campaign and advice being given to them.
Long COVID on a sort of a system pathway level in North East London. And Susan?
My question's totally different, I'm afraid. With the ELF situation, I mean, as you were sort of underlying, they've gradually sort of expanded into different areas and kind of built up. My worry about having one CEO across Barts and Barking, Havering and Redbridge's sort of trust is just that you're talking about two inner and outer London and two totally different cultures, and I'm just wondering what you're doing to address the challenges of bringing such different sort of cultures together.
So I think that latter one would be best directed towards Jacqui, and then maybe Olwyn could pick up on just if there's any long COVID pathways at a sort of a system level that you can assist us with. So Jacqui Smith, please, in terms of the different cultures at Barts and BHRUT and a joint chief exec.
Well, perhaps when we've got more time, we can have a conversation about what quite you mean by two different cultures. But arguably, I think, so I'm not quite sure what you mean by that. I think what we're attempting to do is to ensure that we've got the capacity across both trusts in the environment where we're working now, where essentially the challenges are, as we've heard, getting the recovery right in a way that improves and doesn't exacerbate the inequalities that we've seen grow up during the course of the pandemic, cope with the growing population, and play an active and positive part in the ICS and the integrated system. We think the best way of doing that is by having a sort of strong strategic leader who can engage in the system as our joint CEO, whilst also maintaining and providing some of that group capacity, whilst also maintaining some stability in the leadership that exists both at BHRUT and at the sites at Barts Health, as I said. But there will need to be, and we are thinking about how we do this, some organisational development work in bringing the leaderships of the organisations together to the extent that that needs to happen. But we're beginning to see some really important progress on as part of the collaboration. So if you're thinking about, we've talked about some of the practical results in terms of improving capacity, but we're also, for example, sharing work on equality, diversity and inclusion. We're also sharing work on our sustainability and net zero target work. Wherever I go in each of the two trusts, I quite often hear people saying, and I talked to my counterpart at Barts, or I talked to my counterpart at BHRUT, and it was really interesting. They told me X or Y, and we're going to try and do that. So I think there is, to the extent that there are different approaches, I think we can learn from the best of each as we develop the collaboration. And I think the single CEO enables us to continue making the good progress that we've been making up until this point and delivering the results, which is the only reason for doing it, not a governance change.
Olwyn, in terms of long COVID pathways, is there any across the ICS?
Ben, I think Sam or Ken are going to just outline that for us.
Yeah, Ken probably.
Yeah.
Thank you.
I'm more than happy to sort of answer to that. So the answer is that yes, we do have long COVID pathways. So just for sort of information, obviously, after a COVID infection, although a lot of people recover, there are lots of symptoms that people can have for some time, and we're all familiar with these, including fatigue and shortness of breath. Often they can, if they settle down in 4 weeks, that's fine. But if they go over 12 weeks, it's long COVID. The GPs will assess the patients, do any sort of relevant diagnostic tests, and if they need to be referred to a specialist, like a respiratory specialist or a cardiologist, then they would do so and they'd have their specialist treatment. If, on the other hand, they need a more multidisciplinary assessment and management, then they'll be referred to the long COVID service, which is available throughout North East London. And there's a pathway, and a lot of details are on the NEL Health and Care Partnership website. And essentially, they have a multidisciplinary assessment that it includes sort of allied health professionals, medical, physiotherapists, and so on. There'll be an individual plan based around the patient's need, because every patient will be different, and they would support them in their rehabilitation pathway to sort of let them lead a near normal life as possible. So yes, they're very much in place, and we are referring patients.
Thanks, Ken. I'm going to draw that item to a close now because we're a few minutes over. Thanks, everyone. Everyone who was there for that item, please feel free to leave us at this point. Can I now go on to item number 6, which is the continuing healthcare consultation. I understand we're joined by Diane Jones, who's the chief nurse across North East London, Sandra Moore, who's the deputy director of continuing healthcare, and Matthew Norman, who's the program manager. Diane, we've seen the presentation. Can you give us a brief introduction, and then I'll open it up to questions.
Sure, thank you. As we said, this paper is here just to outline our intentions to want to engage with our community regarding policies where we want to join them and line them across North East London. And it's about the continuing healthcare framework, which is CHC, but also for children's continuing care as well. What we have at the moment is varying policies, because we were once single CCGs, and so the idea is that we want to bring them all together and harmonise that. But we also thought it's an opportunity to work with our communities to look at the best way of sharing what is continuing healthcare, because many of our public are not aware of it, but also getting their views around what should our new policies look like in terms of getting the most out of it for our communities, and that idea about levelling up is that we really want to be able to make sure that the framework is applied consistently across all of our boroughs, so that everybody who may apply for continuing healthcare go through the process in the same way, and the outcome is equitable once we deliver that process and share feedback with our families. And so the items here to talk about how we want to engage with our community going forward. Thank you.
Thanks, Diane, for the concise sort of introduction to that. That's very helpful. But just before I open up to questions, I mean, to what extent is it going to be all the heads of adult social care are going to be round the table with you, developing this as a joint sort of, as much as it can be? Obviously, there are still distinct pots of money, but to try and make it as joined up as possible, that they are in tandem designing this with you. Is that the hope?
Absolutely. And it's not just our directors of adult social care and directors of children's care, it is also our community as well, that we want to be able to really engage so people understand what it is that's within our gift as a system in terms of the policy. Obviously, there is the national framework that we have to work within, but it is definitely a co-production, co-partnership in how we develop these policies and harmonise what we currently have in place. And we don't just want to replace what we have with whatever the policies look like now. We are actually wanting to do completely new policies. There may be good practice that we can see in our existing policies, but we want to make them new and be co-produced across a system.
And do you think you could get to a place whereby, although money is still notionally held by the local authority and other pot is notionally held, but sort of the healthcare side is held by the NHS, to try and, I think we're all possibly familiar with where you get sort of like budget discussions as to who's picking up the tab in terms of X individual, and that's a very difficult case, whereby everyone is almost on the same page, because it's not, although technically you maybe not be able to join them just yet, you can sort of, you've merged and interlinked policy so much that everyone's got buy-in. Is that the end aim of this?
So potentially we can do that, because I mean we've gone some way in doing that, because we have the Better Care Fund. We also have what's called Section 75 agreements, where we do pool money together for the best outcome for our patients. So potentially there is that approach that we could take, and we would like to explore with our local authority colleagues as an option and an opportunity as we move forward with these policies.
Thank you. Members? Councillor Snell.
Thank you. Very succinct introduction. Members were discussing this before the public started this meeting, and the point was raised that continuing healthcare assessments, there's quite detailed guidance from government on how these should be conducted. You know, who picks up the tab for what type of services, but we are aware of the fact that it gets applied very differently within different health bodies, health authorities, I guess it would have been in the old days. And I just wondered if, as part of this review, you're involved in an audit process, basically using beneficiaries of these services to find out what is being provided in one borough but not in another borough, because that would seem to me the most effective way of driving up the quality of provision, rather than perhaps just dumbing down to what costs the least money.
Absolutely, thank you. So, given that continuing healthcare is under my leadership, and my area of concern is around quality and quality improvement, it absolutely is about an individualised assessment of that individual's need, and it's not based on the cost and the budget envelope. What I think we need to look at, though, is the service provision. So where people are eligible for continuing healthcare support, that we look at who can provide the best care for the individuals to meet their needs within what is the most efficient way. And so we do have processes in place to assure ourselves that the packages of care that we are commissioning for those individuals are cost effective, but also meets their needs. And there are variations, you're absolutely right, in terms of the service provision. And so part of what we are doing is looking at what is the the benefits of the services that are being provided. We look at the care homes, we look at the home care packages, and we are looking for the best care for all of our patients across all of the boroughs. So coming together as we are now a single CCG and working with our providers, that is definitely part of what we want to do, is making sure that we are commissioning the right care for our individuals to meet their needs.
Councillor Sweden.
Thanks, Chair. I'd just like to take the previous point a little bit further, and perhaps I should declare that I have been wounded in the process of determining whether various clients or patients are eligible for health-funded continuing care, and have conducted protracted arguments about the interpretation of the criteria. Having said that, I'm very impressed with the paragraph on page 93, which refers to addressing health inequalities and engaging seldom heard communities. And I think part of this comes from the fact that certain parts of our society are less likely than others to actually come to avail themselves of social care, which means the question, other than in something like a hospital discharge situation, the question of health-funded care, continuing care, doesn't actually come into the picture. So in addition to the consulting with those groups, I hope that we will be, or you will be, considering ways in which they could be brought into the ambit of health-funded continuing care. And it's been my experience that in this somewhat adversarial process, that the sharp-elbowed do well, the articulate sharp-elbowed do well. Of course, people who are more affluent have more to gain by being assessed as eligible for health-funded continuing care. So in that regard, I'd like to ask, and possibly if the response is not affirmative, to recommend. My question is, during the consultation, will you be considering the provision of advocacy in the determination of continuing healthcare for those who are being considered for it? And if not, I'd like, Chair, for us to make a recommendation that advocacy be considered as part of this review.
In terms of those that don't have an advocate and don't have a family member available to it, or for all people, are you suggesting? Are you suggesting that everyone should have an advocate, or just those that don't have? Because obviously some people have very able family members who will make representations, and other people wouldn't, and there's much a greater need, arguably, for an advocate in that situation. Do you?
Suggested in the world of social care that an advocacy service be commissioned for those that wish to avail themselves of it.
Thank you.
So two things, and they are both positive answers. In terms of our engagement process, we want to engage with families, but also advocacy services as well, to make sure that we are seeking views across a wide range, and also being able to seek views of those that are seldom heard. And absolutely, where there may be an application for continuing healthcare, if that individual doesn't have family members to represent them, then we would want there to be an advocacy support for them, because in most cases, the patients who we are assessing require some support from a family member or an advocate on their behalf.
I just maybe ought to clarify on that point. You may well have family members who can advocate for you, but the determination of who is eligible for health-funded continuing care is a defined area, and you have to have expertise in health-funded continuing care to be an effective advocate. So I'm talking about advocacies that would be available to people who have family members, but certain family members that would be more effective than others. And if you are talking about hard to reach group with linguistic problems and other impairments to basically working the system. A commissioned advocacy service would be particularly valuable for those, and there are others who would not need it because they can do well in this field on their own.
Thank you. I understand your clarity now. So you're saying that we should make available for families where they choose to access an advocacy service, that we ensure that that is available to families if they so wish, or people who are seldom heard. It's not something that we routinely do, but it's certainly something that we can take away and look at how we can make that happen, so that we can have advocacy support routinely available should people wish to use that, or if they need to use that.
Thanks very much. Thanks.
Councillor Snell?
I mean, my understanding is that, and I haven't updated this recently, but my understanding is that there is an existing service offered in City and Hackney, supported by Mind as a partner. So it's surely critical that we don't lose any of those services, and that has to be part of the analysis, is where this advocacy service is already provided and what we're going to do to make sure it's available universally. So I'd certainly back up that suggestion.
And Diane, can you just explain, in terms of the sort of the driver of harmonisation, is it, to what extent is it cost related, that you've got some of the old CCGs who are proportionately pro rata picking up, say, a greater percentage of the financial burden, to be crude about it, and you're saying, hang on a minute, some of that should be borne by, possibly by the local authority, vis-a-vis something that's just more about pathways and making sure everyone's aligned, so it's not, hasn't really got so much of a financial focus, but it's just more about how there's a single pathway across the whole area, because of course if you're sending people to different hospitals, it makes sense to have a joined up pathway that works everywhere? Or is it a bit of both?
So this is truly about getting consistency in the pathway. We really do want to have that consistency, so that a person in City and Hackney, or a person in Barking and Dagenham, or a person in Redbridge experiences continuing healthcare in the same way, in the way that it should be conducted following the framework. And that the outcomes may be different because the individual's needs may be different, but we really do want that consistency, as we are one organisation, to enable both for staff and clarity for individuals and their families, and for advocates to understand what is the policy across North East London, what is the process. We want to make that much clearer, that we have a consistent process going forward, so that everybody can understand what we're doing, and the rationale for whatever that outcome may have been. And we want to take people on the journey with us. I think our colleague has said that obviously they've gone through a very painful process of continuing healthcare. We see that far too often, that people have to argue or challenge what has been a decision. And so this is very much about our own staff as well, understanding what the policies and the rationales are, so we get them to work to the framework in a way that is consistent, and that we go on that journey with families, that it's not adversarial, that we are very transparent and open about the way we're conducting the whole process from start to finish.
Thanks, Diane. I mean, I think, yes, I mean, I think you'll understand. I mean, we're obviously coming from a position where, you know, local authorities have had their budgets dramatically slashed sort of over the last 8 to 10 years, and obviously there's a concern amongst all of us as we're trying to juggle priorities as councillors, that a consequence of this might be that there's greater budgetary pressure then put on, say, adult social care. So I suppose it's, you know, I take your reassurance this about the harmonisation of the pathway. I suppose it's a job for all of us to go back to our respective directors of social care and just make sure, you know, and ask them and challenge them to make sure that they're happy and joined up with this process, and that it's not having any sort of budgetary impact that then has a knock on other council services. And can I just say finally, this one thing that came out in the pre-meet, in terms of making this consultation accessible to the public, because as you've said, a lot of the people will have had experience of it, will, you know, have had to go through this system. How are you making sure that consultation is genuinely gets out? Because there will be a lot of residents who actually got a lot of experience to give back on this. So how are you doing that bit?
Sure. So I will hand over to Matt shortly, but we're using as many platforms as we can, such as social media. We're also working with Health Watch, because again, we know our client groups may not necessarily utilise social media. So we have drafted an engagement plan working with our comms engagement team. But Matt, do you want to just explain a bit more about the engagement that we're considering?
Sure. So yes, as Diane said, we're utilising Health Watch to engage with the public there. We're undertaking surveys. We're going to be publishing information on the website, and we're going to be putting out leaflets and pamphlets in a variety of settings.
Did I have a question from Councillor Masters?
I'm just slightly concerned in the sense that Health Watch are a body who, by their nature, tend to sort of focus more on consulting with people who are already active sort of around the system. My worry is communities that are kind of underrepresented and maybe not so savvy, and I'm just wondering whether any works. I mean, you've talked about social media, but again, if you're sort of talking about the kind of communities that don't tend to engage, are you doing anything with community groups within the voluntary sector?
Yes, if I pick that one up, so we certainly are, and we've looked at what are the community assets across North East London, and we can see that we have a range of voluntary groups, third sector organisations that we'll be reaching out to enable us to engage with them and through the people that they work with as well. So we want it to be far-reaching. It's not a closed engagement. We want to be as open and accessible as we can. So we're also picking up from others who suggest to us other areas that we should engage with, that we will follow through with that as well. But we do have a range of third-party organisations as well that we're working with.
Just as a very, very quick supplementary, would it be possible to get a list of the organisations? Because I've been there so many times. I mean, I've currently got a bit of an interest in that. I am working in the voluntary sector, but throughout the 10 years I've been dealing sort of health matters, we always hear about wide consultations, and when you actually see the reality, it's so rarely the case. So it would be great if the committee could be sort of furnished with a list of all bodies consulted.
So thanks. Is that okay, Diane? Thank you. Yeah. And Diane, just to confirm, have you now been formally appointed as the chief nurse for the integrated care system? So is that your, or are you? Because I see your title here, or is that something that's still going on?
Yeah, so I'm the chief nurse for North East London CCG. The recruitment process is still happening at the moment for the ICB roles.
Thank you. Thank you. Thanks, Diane. Well, Diane, with that then, I'm going to bring that item to a close and then move on to the second consultation, which is the harmonisation of the fertility services. And again, we've got Diane, Alison Glynn, who's the head of commissioning, and Dr. Anju Gupta, who's the clinical lead. Yeah, Diane, I'm sure I'm grateful for the succinct opening you gave before, and I ask you to do the same again. But I suppose just the key thing that hopefully you can weave into that is that any consultation, if it goes out, is abundantly clear to residents that if we're talking about how many attempts they get, if there's going to be a change to that one borough versus another, or whether the age parameters are going to change, that I suppose, having read it, my primary observation would be to make it a meaningful consultation. It has to be abundantly clear what the consequences are and where you're going. Otherwise, it's not really a genuine consultation. So if you can maybe just address that in your opening.
Sure, thank you. So again, this is something that we're looking to do because we want to harmonise the existing policies. It isn't just a levelling up. We want to use the evidence base to understand what is the right thing to do for our community, and we want to hear from genuinely want to hear from the community to understand the impact of a fertility policy and what would be meaningful for them. So we do want to look at what that would look like in terms of the areas of consideration, being the numbers of cycle, the age of treatment, bearing in mind what the evidence base may suggest as well. And part of our engagement will of course, it will involve, because we'll be very much clinically led, it will involve speaking with groups and getting them to understand, if we chose this option, what that would mean, and if we chose, so there'll be an impact assessment, there'll be a quality impact assessment, but also an equality and health inequalities impact assessment as well, so that we are very clear with our communities around what is possible within the envelope that we have, in terms of quality, but also the service provision, and also what are the impacts of that. So we will be sharing a quality impact assessment as we go through. It's an iterative document that we will want to share and update at the more we engage with our communities. It can be quite an emotive area, as you can imagine, and so we will be addressing this with the sensitivities that we know exist when we talk about fertility. We know that we've had experience doing this in some of our boroughs already, and we want to take the learning of what we've had with our boroughs to enable us to take that forward, again, with as many community groups as we can, to really get views, and like you say, from seldom heard communities, as well as communities where they may be more vocal on this topic as well. So it is something that we want to put out there so that we are sharing our views, but also getting views from others around what would a North East London single fertility policy look like, and what that would mean for our communities.
Whereas the last consultation said in the pack it was cost neutral, I don't think that wording appears in this consultation. Is it cost neutral?
So we don't know if it's going to be cost neutral, because we need to do the engagement to agree what that final policy will look like. So we're not able to predict what the cost will be, but we're not putting a cost on it. This isn't a cost saving initiative. This is about getting the right policy for our communities. And once we've done that level of engagement, we will have an idea about what the cost would look like. But we did want to say up front, because we haven't decided what the policy will look like.
Members? I saw Councillor Hudson first.
If the cost is a lot more, how are you going to fund it?
So I suppose we'll have to look at what other areas of service provision, with efficiencies that we've just talked about, with the long waits. There are other ways of working that we may be able to divert money from one area to another, because we are more efficient in the way that we're working. But it's not something that I can say up front that we have the money available for this service, because we don't know what that will look like. There would definitely need to be a financial impact of what this policy will be, as well as doing the quality impact assessment, and that would go through due process to understand where we then get the money from to enable us to meet the needs of the policy.
Councillor Snell.
So I'm going to, in a way, duplicate the point I made on the previous paper. It does seem to me, if we're looking at CHC provision, the people who can help us do it properly are the advocates for clients affected by those decisions. And again, in this case, it would seem to me that we should be working not just on community engagement, but very specifically with critical friends. And a case that was brought to my attention earlier tonight, in fact, was with regard to comments from Stonewall about fertility services for gay couples, and a feeling that there was a difference between the different health authorities, and that possibly City and Hackney's was discriminatory against gay couples seeking to have fertility treatment. So I wondered if, as part of this process, we could actually review who is out there commenting on the fairness of provision at the moment, and that we look at that analysis, and that informs the decisions that we reach.
So I'll bring in Alison, because Alison's been working with colleagues in City and Hackney on the review that they're undertaking in relation to the sexual health services. But just to say again and reiterate that we absolutely want to engage with all interested parties in the policy. It will be an inclusive process. that we want to undertake, so that we don't want to disregard anyone that has a view on what the policies will look like. But I'll hand over to Alison, you may want to say a bit more.
So yeah, so we've engaged with clinicians in local specialist trusts and in with Guy's and St Thomas's Trust, and we've also asked them to kind of put us in touch with patient groups that they may wish us to talk to and engage with around developing the draft policy. Chris Lovett, who's I see was on the call or is on the call, has got in touch for us to have a conversation with him and other public health colleagues across North East London, because I know they and in regard to this and their links with sexual health public health policy. So so we're making those contacts and those links with individuals and with groups, and we've done some engagement already with some local internal LGBTQ plus groups, and also BME and other staff networks. So we're doing as much pre-engagement as we can as it stands at the moment, and obviously there will be a much wider engagement when we go into the engagement in the summer. But really encourage you, if you do know groups that you think would be positive for us to contact, we're really happy to accept any suggestions and add that to our stakeholder mapping.
And Alison, I mean, Chris's observation there, I mean, will there be a needs assessment to support the policy development?
So, so what we've done is a review of the existing policies. We've had an independent health policy support unit who have done a comprehensive review of our existing 5 policies, and they've judged that, assessed that against the NICE guidelines, along with the HFEA guidelines and various other ones. They've also then done basically we've undertaken a big mapping exercise in terms of what the impact on cost, capacity of the service, and also on patient outcomes. So how many births that might result in. So that's the review we've done so far, and the clinicians in the clinical review group are looking at that. And then in terms of needs assessment, that will hopefully come up from some of our conversations with Chris, but we are also looking at engagement with staff networks as well and other patient groups. But I'm not sure if that doesn't cover it. I'm not sure if I have covered your question in terms of needs assessment.
Thanks, Alison. And maybe, Alison, can you just help us with what's the variation at the moment across the ICS footprint in terms of, does it vary that some local authorities will give residents 1 try, others will give residents up to 3 tries? I haven't got a gauge as to what the age parameters would be. I mean, is that the differentiation we're talking across different local authorities at the moment between 1 and 3, or is it even greater, or where are we?
So in Outer, in BHR, we offer up to the age of 40 1 embryo transfer. A cycle is what people call it, but it's actually an embryo transfer. And in the inner North East London boroughs, we offer up to 3 embryo transfers up to the age of 40, and then 1 after the age of 40 up to the age of 42. So that's one of the reasons why we're desperate to harmonise this. Really, is it's just the inequity is obvious.
And I mean, just going back, I mean, I appreciate Diane saying that this is sort of evidence-led, and that the budgetary things we consider afterwards. But if, just to give us some idea as to the realism of this, is if you adopted the policy in Outer that's in Inner of 3, then plus 1 try, pre-42, I mean, have we got any grip as to how many extra millions that may cost? Because you said there had been some sort of financial analysis done.
Yeah, I mean, at the moment, it's a bit difficult because we've actually kind of looked at a different parameter, if you like, because actually what we provide in inner North East London is also only up to the age of 42, when NICE guidelines actually include 42-year-olds. So it's a bit difficult for me to kind of disaggregate what that additional cost would be. But yeah, it can be, it's in the millions, I would say, in the low millions though. So if we were to go full changes, but there are lots of areas where we are, well, there are lots of other areas that are also not in line with the NICE guidelines as it stands at the moment. So we need to make sure that we are taking into account all the factors. It's not just about age and the number of cycle stroke transfers. So there's a lot of parameters that we're also looking at, and you will see in the list the things that we are looking at around IUI, for example, which comes back to the Stonewall campaign.
And very briefly, does the NICE guidelines give a guidance as to how many tries there should be, or is it silent on that?
It recommends 3 cycles, and you could have more transfers within that 3 cycles, but it would depend on the individual.
Fine. Okay. I mean, unless there's any further, I mean, it strikes me that I think we will want to see, if we can, please, Diane, for both the consultations, but I can, because as you, well, I mean, both could be emotive in different ways, but I can see this one in particular being a lot of interest in it. So I think we do want to see the actual consultation document that's going out to members of the public, please. And I think, to the extent that it's not there already, I really think it needs to be, because I can just imagine one way the consultation is done, where it talks about harmonisation, and so you get the green light, but people don't realise, in fact, that they are talking possibly about 3 going down or 1 going up or whatever. I think if that is an active consequence of this consultation, that needs to be very much part of it and very much clear within it. So you don't get, I think it's entirely counterproductive to sort of try and whitewash over it in a vague consultation, because that's just going to cause disengagement and more distrust with sort of NHS consultations. So a real plea from us, please, for it to be as open and as candid and dealing with it head on as we possibly can be. And then I think we do want to see the consultations, please, because then I think, you know, we may want to take a running on both matters, may want to come back to them in due course. So unless there's any other points, no, I will draw that to a close. Thank you. And so thank you everyone who was there for those 2 items. Please feel free to leave, because we're just going to get a very brief update now, item 8, from Councillor Richard Sweden on the Whipps Cross Scrutiny Commission that's been formed, just to look at that. Richard.
Thanks very much. I'll just draw members' attention to the brief report in the pack, from page 100 to 103, 102, or 100. Yes. We have one session remaining, which will take place at the end of this month, which will be looking at sustainability and flood prevention. And each session has an update. As regards the previous, the last meeting, which was on the 26th of January, Alistair Finney reported that the outline business case was not yet ready for submission to central government, because effectively the ink's not dry on the cheque, and we have to get that far before they submit the outline business case. We had an interesting session looking at bed numbers, and certainly the trust agreed that they needed to build sufficient flexibility into their modelling. We had a couple of expert witnesses on bed modelling, and I think one of the submissions that I recall was they were slightly critical of the work that the independent work that had been done by the trust, in that they didn't give different scenarios. So, for instance, when we were looking at the pandemic, there would be the best case, the worst case, and the most likely, or something like that. But there was only one scenario given, and at the end we recommended that they should continue to revise the bed capacity insofar as additional information came in that may affect it, and perhaps building capacity to change in terms of, because only outline planning consent to be given in terms of planning consent. We move forward, as I said, to look at flood prevention and sustainability. The question of conducting a statutory full consultation is still in the air, and that has also been suggested for the next meeting, which will almost certainly come up. Following the discussions that I'd had, there was a detailed letter sent to the CCG, a new big CCG, requesting this, and that will probably form part of our discussions next time. I'm happy to answer anything that anyone's got to ask.
Richard, the discussion on the statutory consultation, that would be that because it's a change of, the argument in favour of it or in support of it would be that because it's a significant change in service, it automatically triggers the need to go out to full consultation. Is that the
argument in favour? The argument against is that it isn't a significant change in variation, and not a change of location. I hope very much that we'll reach consensus, because the Barts Health and the CCG, Barts Health, is very sanguine about having consultations on anything that could be perceivably be a significant variation, but are very unwilling to get involved in a matter of process which could significantly postpone the bringing forward of the hospital. And second, and I suppose erroneously to suggest there isn't unanimity about wanting the new hospital, because there is unanimity in wanting the new hospital.
Thanks for explaining that. Okay, unless there's any, we've got 3 minutes left. Unless there's any other questions to Richard on that, we're not core because Tara Hamlets aren't here, so I can't formally agree the minutes. So that'll have to wait for another occasion. Work programme is at the back of the agenda. I certainly think when we come back in June, we've got the item with respect to what is the update. The ICS will just be about to take off at that point, so that's got to be on the agenda. Whether there's sort of like another, if members like the format that would have an ICS update, maybe the second thing would be like a dashboard of the main priorities we had today, and then query the other 2 slots if there's anything that the health leaders want to bring in terms of consultations, or there's normally something sort of comes through. Councillor Snell?
I found it quite interesting, that question that was answered about what we were doing to deal with the backlog of surgery. And I'm not sure we've been fully informed of where these various specialist centres are being developed, who's got which patch. And then presumably the implications for our residents on how accessible they are, how easy it is for their families to visit them, and all that sort of thing. So I would welcome an update when the whole process is more developed. It sounds as if it's work in progress, but at some point, can we perhaps include that in one of the update reports?
Yeah, I think that's a very good idea. And Susan, Councillor Masters?
I just find it interesting, because to me this is just an extension of what was going on pre-pandemic, where we were already sort of moving towards having these kind of specialist hubs like, Barts for cardio, Royal London for, I can't remember the word, but trauma, that's it. And then, the gateway always was going to be this orthopaedic centre of excellence. Yeah. So, I mean, to me, it's just sort of sped up something that was had already been agreed, using sort of pandemic for justification.
Yeah. Okay. Well, it may be. I think I like the idea of having that as a specific item. So I think what I haven't seen is sort of like a map showing that this is where, to be quite crude about hip replacements are going. Then there's how does the geographical patch carve up for our residents, and where does it mean people from Newham having to travel for X and X for Y? So yeah, I think that's certainly something then we can ask. I mean, I think Olwyn alluded to the fact that will be coming back, but it's mainly and I see Mary nodding, but it may be that when that does, we could have a helpful diagram that fully explains that fully explains it for us. With that, then I'm going to Councillor Hudson.
Chair, very briefly, if 3 out of the 4 councils are represented, we are quorate. Now, unless everyone else here is from Hackney, I think we are quorate, and so we can approve the minutes.
I think I'm told it has to be one. The Constitution says it has to be one from each of the boroughs.
So I presume then everyone else here is from Hackney.
No, but you need one from Tower Hamlets. We don't have one from. We need one from Tower Hamlets. Technically, but in any event, it's a small. We can agree the minutes next meeting when someone from Tower Hamlets is here.
Then finally, I'd like to say we're all conscious that elections are coming up. Mine are, our cities are later this month. I may or may not be back later on, but I'd like to thank everyone for the collaborative way we have worked, the way you've chaired the meetings whilst you've been in charge, and your predecessor also. I wish you all luck in May.
I think that's likewise from all of us.
We may not be party political, but we have contested elections in the city.
I think that well said, Councillor Hudson. I think we all feel the same. Thank you, everybody. And so with that, I will formally close the meeting, and next meeting is late June. Thank you, everyone.